Hello. Uh, Let me introduce myself. I am Dr. Deepak Shankar. I head the Department of Nephrology and Transplantation in Aran Tagore International Hospital, Kolkata. And we are a big nephrology unit doing around a lakh of dialysis in a year and around more than 500 transplants in a year with a large experience. Uh, I thought I'll be speaking about how to develop a transplant unit in smaller areas. Most of the cities will have a transplant unit, but we have smaller states like say Northeast states and other states where we do not have transplant facilities. So it's always ideal to have a transplant center in each city at least. And I'm going to talk how to develop a transplant center. See, as you know, the incidence of ESRD in India is very high. It is around 151 to 232 million per million population. And the transplant requirement is not less than 1 to 2 lakhs per year. And we are hardly doing 6,000 transplants a year. So there is a big gap between the requirement of transplantation and the number of transplantation we are doing in the country. And why should you do a transplantation in a end-stage kidney disease where patients need some form of renal replacement therapy? That's because the transplantation is economically more viable. This is significantly cheaper than the dialysis, whether it is hemodialysis or peritoneal dialysis. It also improves the quality of life. It gives you almost like a normal life, and obviously it gives a longer life. See, on hemodialysis in best of centers where we do 3 dialysis a week, the 5-year survival is not more than 40%. And in my practical experience, in most of the centers, the all patients, you will find a new set of patients in 5 years time. So all patients, almost 80-90% do not live beyond 5 years. Whereas in transplantation in our center, a 10-year graft survival, again, not human survival is always better than graft survival, is around 75%. So it's significantly better than dialysis. Besides, in our country, we have a young population. See, our country's mean age, population's mean age is 24.8 years. So we have a young population, unlike Western countries where usually the patients who go into ESRT are very senior people beyond 60s. These are the people who are in their productive age. And as a country, we definitely will gain if we do the transplantation. And the transplantation, unlike dialysis, which continues, goes on and on and on, makes the family as well as the patient fatigue, both physically as well as economically. The transplantation provides an immediate solution. And the mode of treatment is centered around the family. See, you have a family member who donates the kidney, you have a patient, they go to the hospital, transplant is done, they are back, and the family takes care. It is not like dialysis that the center has to be involved, the technicians have to be involved, the hospital has to be involved, the transportation has to be involved. There are so many involvement. So it's very easy. It's a it's a family-based treatment. And nowadays we have better donor pools. The relatives can donate, and earlier days the ABO incompatible patients are not donors are not donating. Now we have in each family around 40% people will be of different blood group, and nowadays we have means and methods to do all those ABO incompatible transplantation. So you can have more and more live donors if you do not get a disease donor, if the disease donor program is not that good in your area. But what are the challenges for a transplantation? See, all centers, all people may not have adequate experience. That could be a challenge. And they may not have a suitable infrastructure. But the more important challenge is lack of confidence or a state of resignation. See, I'm doing dialysis as a nephrologist, I'm treating patients, doing a biopsies, and they are coming and going home. Why I take extra botheration of doing transplantation? And then there is a transplant tourism, not in a larger sense, but in a smaller sense. In the sense, see, we in Calcutta, we get patients from Northeast, from Bangladesh, from all surrounding states, eastern states. So this is a kind of smaller transplant tourism, which probably prevents people to develop a transplant centers. And how do we overcome this? Overcome is by simply doing transplantation. You do a couple of transplant, you will be confident, your team will be happy, your hospital will get a name. See, transplant in a smaller town, if you do, you are lifted to a different group, different class, as a doctor, as a transplanting person, as a coordinator, and as a hospital in total. So you just go on doing transplantation. The first, second, there may be a failure occasionally, but if you go on continuing transplantation, you will be achieving success. So now, what do we need for a transplant? See, transplant is always a team affair. It's not an individual kind of treatment. So normally the nephrologist or the transplanting surgeon works as the coordinator. He has to be a, a team leader. He has to have good relation with all departments. A transplant can't be done alone. So you have to have good human relations with not only the departments, with your dialysis technicians, with your nurses, with your secretaries even, who will help you in preparing papers and all that. And then what other requirement we need in a hospital, which most of the hospitals will have either in the government sector or in the private sectors. The dialysis unit, you have to have a dialysis unit to start transplantation. And almost all hospitals will have radiology or imaging centers. We need the CT scans, we need the ultrasound and X-rays for evaluation, for post-transplant management. We have to have a biochemistry department, which all hospitals have. You need very frequent electrolytes, urea, creatinine, etc., to be done. So that facility should be available. A pathology is of help because you may require to do a biopsy post-transplant where you need a report in a day or two to act on that. If there is a rejection, you need to know very early. And this, at least the acute biopsies, one can train the pathologist. It's easy to diagnose acute rejection, so the pathologist can be trained. Then you need not have an immunology department, which is very important and which is expensive. Only centers where they do large number of transplant, like say ours, we can have an immunology department. But nowadays there are a lot of national labs which support you immunologically. You can do your HLAs, you can do your cross matches through them. So you don't have to put money on that. And uh, if in the city there is a nuclear medicine department, it is helpful. It is helpful in the sense when you choose a live donor, and most of you will have live donor because disease donor numbers are low and it will take time to grow. Then you have to investigate, find out whether his or her both kidneys are functioning properly. So a nuclear medicine department will help. Otherwise, you can send for testing somewhere. And drug labels, you don't need to have drug labels because you can send it to national laboratories. But in a longer run, when you do more number of transplant, maybe around 10 to 12 in a month, you should have, it's very simple. You need to have just a machine to evaluate the mostly tacrolimus level or occasionally cyclosporine level. What departments are very closely associated? Of course, anesthesiology. I'm talking besides nephrourology or nephrology and surgery, which are obviously the main department in the transplantation, but anesthesiology and the anesthetists need to have experience of dealing with end-stage renal disease patients because they are anesthesia, they are immunosuppressed, they have uremia, even though they are on dialysis, so their anesthesia will be little different. So they should have experience. The cardiology department, almost all hospitals will have a cardiology department for evaluation of recipient donor and in any other problem post-transplant. Of course, a obstetrics and gynecology department and gastroenterology department for dealing with viral hepatitis and other gastrointestinal problems. What manpower were required? A nephrologist who are normally trained in transplantation, but there are smaller centers where they have training and there are not good number of transplantation. So a nephrologist need to have some experience in transplantation. The residents, because post-transplant they need 24 hours cover the patient. So somebody has to be there at mid of night for some kind of emergency. So there should be residents who can be trained by the nephrologist or who can be sent to training in the center where they are doing large number of transplants. The surgeon has to be trained. The only general surgeons cannot do. So surgeons has to be trained ideally for a year or more, or at least 6 months in a BG unit like ours. So surgeon has to be trained. As I said, anesthesia needs little bit of training, not much like surgeons, but a little bit of training. We have to train the transplant nurses. You can, if you don't have transplant facilities nearby, you can send to centers to train the transplant nurses. The dialysis technicians will be there, but they should be well acquainted with the plasmapheresis. Suppose you have an antibody mediated rejection post-transplant, you have to do the plasmapheresis. Suppose you have a bio-incompatible transplant, you have to do the plasmapheresis. And of course, a coordinator to arrange the things. So that's very essential. Then you should have a good transplant room where everybody will not enter. It will be a secluded place and it will be a clean and kind of sterile place where the transplant and transplant care team will only enter and take care of the patients. You need to have two OTs which will be required simultaneously, one for the donor organ retrieval and other for the recipient. And you should have regular follow-up OPDs because these patients initially will need very regular follow-up. So you should have regular follow-up OPDs. Where from your patient pool will come? So your dialysis patient will be your first pool. So you must have good relation to dialysis patient. In fact, I always tell my students that whenever a patient presents with advanced renal failure, you definitely should talk about transplantation. We normally say you go for dialysis and you do not talk about transplantation. There is a study where they have shown if when the GFR is 30 ml or less, if you start talking to the family, the percentage of donor from the family goes 4 to 5 times higher than if you talk in a late stage. So start talking to the patient from the early that transplantation is important. Transplantation is a definite treatment. Unlike dialysis, it is cheaper, it gives you a longer and very good quality life, so that your dialysis patients will be your transplant recipients. And you also should, once you are successful, you can avoid transplant tourism. As I said, they won't be going to see Calcutta, Delhi, Bombay kind of areas. So they can do the transplantation there. It is very easy because their family will be there. They don't have extra expenses of staying outside the hometown. So you can always motivate them and keep in touch with the media. Suppose you do successfully transplant a couple of transplants, the media should project it so that your hospital is known, you are known, people will have trust on you, and then gradually you will grow as a transplanting physician or surgeon. A lot of administrative support will be required. It is probably a little easier in the private sector, but it will be difficult in the government sector because for small things, you have to go to your administrator. So keep a good liaison with your administrator. Talk to them about your requirement, your OT requirement, your unit requirement, and keep a good liaison with that. Then in government sector, you need to be talking to the politician because economics comes there. In private sector, patient pays. In government sector, you need to see that the hospital, the government supports. Nowadays, governments are supporting health problems, supporting patients in health problems. So you can take help of your politician, keep liaison with them. Then comes legal procedure, which is very important. You should be extremely, very, very sure about your legal standing in a transplantation. When a patient comes, and if there is a family donor or close donor, then voluntary donor, then yeah, initially you have to take state government's permission to be a center of transplantation. So you have to have the inspection, you should have the things ready. Then normally nowadays the state ethical committee gives permission. So in all cases, you take the permission from state ethical committee. If there is a legal hassle, if there is some problem post transplant legally, then your transplantation will you can't do transplantation ever. So you be very, very comfortable with that, and keep all the records. A coordinator is required because your record may be required later on. So keep all records properly and do everything or above the table. So you be very, very sure that you are doing the right kind of things. That's very, very essential, so that the program goes on. So it all involves a complex teamwork, but I'm sure this can be done. And the kind of pleasure, the kind of satisfaction, the kind of kind of kick you get out of doing transplantation, taking the stress of transplantation is immense. So do not get bogged down by the responsibility. You will find pleasure in doing transplantation. And we as a center, we have already developed 5, 6 centers for in transplantation. We as a center, I give you words that I'll be there to help you in training your sisters, in training doctors, in training surgeons, in training residents, and hand holding. Initially, I can send our people to actually help you in transplanting in first 1 or 2 cases. And then once you are confident, you can continue doing that. We can arrange a local visit, talk to your patients, talk to you, and so that you can develop as a transplanting unit, and you can be of great help to your patients. Thank you very much.